So here's what we have to focus on, or the treatable risk factors for stroke. High blood pressure, high cholesterol, diabetes, smoking, obesity, atrial fibrillation, this irregular heart rhythm, as well as transient ischemic attack, which we'll talk about more in a minute. So here are factors that we can treat today. Here are factors that people can talk about with their doctor, okay? Lowering the blood pressure, lowering that bad cholesterol, stopping smoking. If you stop smoking today, your stroke risk will go down to as if you never smoked a day in your life within 2 to 4 years. So it's never too late to stop, okay? These are things that we need to treat on an outpatient basis to prevent strokes from occurring. So in terms of our treatable risk factors, we can make a significant difference in treating these, okay? Here's the percentages of the relative reduction of another stroke while treating high blood pressure, diabetes, high cholesterol, stopping smoking, okay? And if we do nothing about any of these risk factors here, just being on an aspirin or aspirin-like medication will reduce your risk of stroke by 20 to 37%, okay? So just being on a baby aspirin a day can lead to a 20 or more % greater reduction of stroke. And this number here with Coumadin, so Coumadin is a blood thinner. And when people have atrial fibrillation, this irregular heart rhythm, you can get blood clots. And Coumadin can dissolve those blood clots and decrease the risk of stroke. Now, there's some people who cannot be on Coumadin. They cannot be on blood thinners for a variety of reasons. And if that's the case, then aspirin is a backup, but obviously aspirin is not as effective as Coumadin in preventing stroke with atrial fibrillation. So I put this up not to give everyone an anatomy lesson. There'll be no quiz at the end of this. But I put this up for people to realize that stroke can present in a lot of different ways. And it depends on the part of the brain that's affected in terms of the stroke symptoms that you have. So a lot of people are aware of heart attacks causing chest pain, chest pressure, shortness of breath. Heart disease and heart attacks are a lot more readily recognizable than stroke symptoms, because stroke symptoms, well, it depends on which artery is affected. If you affect the artery to the motor cortex, you're going to have weakness on the other side of the body. To the speech area, you're going to have expressive speech problems. So the symptoms of stroke depend on the part of the brain that's affected. But let's talk about some common stroke syndromes. So with stroke, we're really focusing on symptoms that come on acutely and typically affect one side of the body. So sudden onset of weakness on one side of the body, within the face, arm, and leg. Sudden onset of numbness on one side of the body, within the face, arm, or leg. Sudden incoordination on one side of the body. Difficulty speaking, our fancy term in the medical vernacular for a speech problem is aphasia. So people who know what they want to say, but they can't get the words out, okay? That is aphasia. Sudden trouble seeing in one or both eyes, typically blindness in one eye, sudden difficulty walking, and then a sudden severe headache. Usually people describe it as the worst headache of their life, associated with any of the above symptoms or in isolation, okay? And in particular, that's concerning for a hemorrhagic stroke or bleeding into the brain. So we have some information in the back, and we have some handouts we're trying to deliver to everyone. If you didn't get one on the Act Fast program, please on the way out, we'll have some handouts. This was devised by the American Heart Association. And what this is to try to, it's a public awareness campaign in terms of stroke. If you are with someone who has sudden onset of symptoms, this is a nice mnemonic that people can try to remember. F-A-S-T, F for face, A for arms, S for speech, and T for time. Because time is of the essence when evaluating and treating stroke. So face, ask the person to smile. Is one side of the face droopy compared to the other? A for arms, ask the person to raise their arms. Does one arm drift down compared to the other side? Speech, ask them to repeat a simple sentence. Are they able to get the words out? Is it all garbled? Does it make sense? And then T, if you see any of these signs, you need to call 911, okay? Stroke is a medical emergency. Even if symptoms come on and then they appear to be improving, and even if they go away entirely, this is still a medical emergency. And people need to call 911. They need to be seen in the ER. So if you or someone you're with is experiencing stroke symptoms, call 911. Do not try to drive, okay? We're lucky to have very good EMT, emergency personnel services on the Cape. They can start treatment and start an evaluation in your home or wherever the location may be, okay? If a patient drives themselves to the hospital, there's going to be a delay in getting treatment. And we'll talk about that in terms of the timelines of various treatments in a minute. And again, time is brain. The sooner we treat a stroke, the better the long-term outcome. With every loss of blood, every minute that the brain does not have enough blood, 2 million brain cells die. Now, fortunately, we have a lot of reserve. We have about 100 billion altogether. But every minute that goes by, 2 million more brain cells die. So I like this slide just because it gets the point across that the time is brain. And like Van mentioned, we're very fortunate out on the Cape to have 2 award-winning stroke centers. We'll talk about this a little more at the end, but since 2005, the Mass Department of Public Health has had a designated stroke center program by which all hospitals involved have to meet a very extensive list of criteria. And we do this, and fortunately we do it very well, and we've won some awards recently and had some nice recognition, which is always appreciated. So in terms of the treatment of stroke, first off, every patient that comes in is going to be evaluated for a medication called TPA. And we'll talk a lot more about TPA on the next slide. TPA is the only FDA-approved medication for the treatment of ischemic stroke. Okay? But if people do not qualify for TPA, we're going to start aspirin and other medications. Sometimes people need surgery to remove blockages in arteries, in particular if they have significant blockage of the carotid artery. Now that surgery usually isn't done acutely. Usually we wait a few days to make sure that everything's stable. Rehabilitation is a very important part of stroke treatment, and everyone at the hospital will have a physical therapy, occupational therapy, speech evaluation. And then hemorrhagic stroke, the treatment of that is very different. In general, we have to make sure the blood pressure is well controlled, and occasionally we need to intervene surgically to remove that blood. So getting back to TPA, so again, this is the only FDA-approved treatment for ischemic stroke or a blocked blood vessel. TPA is a clot buster. It dissolves clots in brain arteries. And it's typically given peripherally through an IV, just like we give many other medications IV. Now, even though it's our only medication, it's only given to 4% of patients in the US. Only 4%. And the reason for that is there's very strict criteria for who can and who cannot receive this medication. Okay? The most stringent limitation on whether or not we can give TPA is the time window, and that's why time is brain. Okay? There is a 3-hour time window for which we can give TPA. And beyond that window, the benefit decreases significantly and the risks increase significantly, okay? There was one trial recently in the last year that looked at TPA in the 3 to 4.5 hour time window. So it's off-label use. It's not FDA approved, but off-label use, we may be able to give this in the 3 to 4.5 hour window. But we know that this medication does not work as well in the 3 to 4.5 hour window. It doesn't work as well in the last hour and a half of the 3-hour window. It works much better in the first 90 minutes than the last 90 minutes of that 3-hour window. So time is brain, and the sooner we can give this, the better the outcome. In addition to the time window, there's many other reasons why we couldn't give TPA, recent surgery, other procedures that people might have had recently. And I will say that almost all of the trials for this medication, for TPA, excluded patients over 80. Now that being said, we give TPA to patients over 80, but in all practice, we all know that the benefit of TPA is less, or can be less, and the risk of bleeding is more. In terms of the benefit of TPA, 1 out of 3 patients who are given this medication IV will have improvement of symptoms. And again, that benefit decreases with time. And what is the risk of TPA? Well, the main risk is bleeding. Okay? And the longer time goes by, the higher risk of bleeding into the brain. Overall, there's a 6% risk of bleeding into the brain when we give IV TPA. Now, fortunately, the number of significant bleeds that would cause a patient worsening is closer to 1 to 2%, but the overall risk is 6%. And again, this is higher in patients over 80. For every 100 patients treated with IV TPA, 32 patients will benefit, but 3 will be harmed. So no medication is without risk. The treatment of hemorrhagic stroke is very different. Obviously, we need to determine the cause of bleeding. Was this due to a leaky blood vessel, due to chronic high blood pressure? Okay. Sometimes people need surgery, and we're very fortunate at Cape Cod Hospital to have an excellent group of neurosurgeons, Dr. Murray, Houle, Papavsilio, and Akata. We're very fortunate to have them. So when people need emergent surgery to remove this blood clot, we're able to do so. And I will mention that all the bleeding strokes, all the hemorrhagic strokes that occur on the Cape are transferred to Hyannis, to Cape Cod Hospital. So cases from Falmouth will be transferred to Cape Cod Hospital because that's where our neurosurgeons are. So as equally important as stroke is the term transient ischemic attack, or TIA. Now, some people refer to this as a mini stroke, but that's not a medical definition. We don't use that term as doctors. And what a TIA is referring to is stroke-like symptoms that come on and get better. And usually these symptoms get better within 5 to 10 minutes. Most last less than 30 minutes, but the vast majority are actually 5 or 10 minutes. And this occurs when there's a lack of blood supply to the brain for a short period of time, but it's reversible. Eventually that blood flow is restored, and that's why symptoms are transient. They do not persist. And a TIA is a warning sign of a stroke. After a TIA, people are 10 times more likely to have a future stroke, meaning the same symptoms, but coming on with permanent deficits. So this is the time when we have to intervene. Do not ignore stroke symptoms because they got better in a few minutes, okay? This is an opportunity for you and your doctors to sit down and talk about high blood pressure and high cholesterol and diabetes and smoking, and to start you on an aspirin if you're not on an aspirin-like medication. This is the time that as doctors we can intervene and prevent permanent symptoms, prevent a future stroke. The risk of stroke after TIA is highest within the first 2 days relatively. So after a TIA, the risk of stroke in the following 48 hours is 4 to 8%. Okay? Overall, it's about a third in 3 years and 50% in 5 years. But relatively, it's a very high amount. It's very prevalent in the first 2 days afterwards. So that's why people need to be evaluated urgently. And there are risks of which particular transient ischemic attacks, or TIAs, may progress to a stroke. Number one is how long did the symptoms last, if they last greater than 10 minutes. Number two is a history of high blood pressure and diabetes. The symptoms that people had with the TIA, was this weakness on one side of the body, was it expressive speech difficulties, as well as age greater than 60, are all risk factors to be closer to that 8% than the 4%. And again, this is the time that we have to intervene. This is the time that we have to start treatment, do the necessary testing to prevent a stroke from occurring. So when people come into the ER, come into the hospital, within 20 minutes, everyone will have a CAT scan. And a CAT scan is a brain imaging scan, which is a great way to look for bleeding. So we can categorize stroke symptoms in terms of hemorrhagic and ischemic right away. We'll do blood work to look for diabetes, to look for high cholesterol, to look for risk factors of stroke. Heart monitoring to look for atrial fibrillation and other irregular heart rhythms. Blood flow tests to look for blockages of the carotid arteries or the vertebral arteries on the back part of the brain. We can do that with a carotid ultrasound, a carotid duplex. We can also do MRIs of the blood vessels called an MRA, or a CAT scan of the blood vessels as well. And then an echocardiogram, which is an ultrasound of the heart to see structurally is there any heart problem that might predispose to stroke. So this is a CAT scan, and the main reason for seeing this is to realize that a CAT scan does not show acute ischemic stroke or lack of blood supply nearly as well as an MRI. So everyone comes in through the door, they get a CAT scan to make sure there's no blood. And there is a large area of stroke here. Now that's relatively subtle, this gray, vague area, but you can see it definitely looks different than that opposite side of the brain, and this should be a mirror picture, okay? And this is at 24 hours. Obviously, at 72 hours, the area of stroke is much more apparent. And this is actually a large stroke affecting the middle brain artery and is pushing against the other side of the brain because of the size of the stroke. So clearly, strokes are easier to see on CAT scan at 3 days and beyond than they are acutely in the first hour or two. So that's why we have MRI. Because on MRI, within 5 minutes of a stroke, we will see a bright spot if there is any reduced blood flow. So that's what we're looking at here. There's other ways to look at the brain. This is another CAT scan here. And I put this up to make people realize that this is an old stroke. When you have a stroke, there is irreversible injury to the brain. There is permanent damage, and we will always see this loss of brain tissue in the area of where the stroke was. So this is a stroke that occurred over a year ago, but that area of brain does not come back. And this is looking at an MRA of the brain. And like the CAT scan should be a mirror image, this should be a mirror image too, where these are the two back arteries, the two vertebral arteries, and then there should be another carotid artery right here looking like this, okay? And there is no carotid artery right here because it's blocked, and it's blocked right here at the base, okay? So this is one of the ways that we can look for blockages. Other ways we can do that, which we do more routinely, is a carotid ultrasound, all right? So if you picture a garden hose here, it should be nice and wide open. Okay. Unfortunately, in this patient, and in many cases of stroke, there's atherosclerosis, there's plaque buildup, there's fatty deposition within the wall of the artery. And this plaque buildup can increase to the point where eventually it can clot off that carotid artery entirely. A nice way to look at the heart is an echocardiogram. It's an ultrasound. There's two ways to do that. One way is to put an ultrasound probe on the chest and get a good look. Another way, and a way to get a little better look at the heart, is to put a small tube down the throat. And the food pipe sits right on top of the heart. So we're closer to it, and we can get a better view of the heart doing it that way, what's called a TEE, opposed to a transthoracic or across the chest echocardiogram. To do that TEE, it's a little more invasive because we have to sedate the patient, similar to if anyone's ever had a colonoscopy or endoscopy, we need to make you pretty sleepy. We would do the same for that transesophageal echocardiogram. So in terms of the goals of our treatment, number one, we want to limit and reverse any ongoing brain injury. Everyone is evaluated for TPA. But not just TPA, we're starting aspirin and other medications that we need to. We're trying to prevent any worsening of neurological symptoms by controlling swelling in the brain, keeping an eye on any bleeding. Prevent early recurrent stroke, because 5% of people who have a stroke will have another in the next 30 days. And the diagnostic testing, we just took a look at MRIs and echocardiograms and carotid ultrasounds, and secondary stroke prevention, talking about high blood pressure, high cholesterol, diabetes, smoking, as well as looking for any irregular heart rhythms such as atrial fibrillation. And then rehab. We have some excellent rehab services on the Cape. Physical therapists, occupational therapists, speech therapists. Most patients with stroke will have, essentially all patients with stroke, will have some rehabilitation afterwards. And the majority of these will be at some of our fine rehabilitation hospitals. In some instances, people can go home and have an outpatient rehab program. So I've mentioned aspirin a few times, and aspirin is a very effective medication in reducing the risk of stroke. If we do nothing else, just putting people on an aspirin reduces the risk of stroke by about 20%. And it does not matter what the dose is. A baby aspirin or 81 milligrams is just as good as 325 milligrams of full strength, which is just as good as 2 grams of aspirin. It is not dose dependent. Just being on an aspirin leads to a reduction of stroke. Then there's 2 other medications, Agranox and Plavix. These are newer medications. They're more expensive medications. They do work a little bit better than aspirin, however. And aspirin started within 48 hours of a stroke improves the long-term outcome, okay? And this is without increasing the risk of any significant bleeding. So in terms of outcome after stroke, 1 out of 3 patients will have some degree of permanent disability. And the degree of disability depends on what parts of the brain was affected. So people can have varying degrees of weakness on one side of the body, numbness on one side of the body, incoordination on one side of the body, imbalance, speech and swallowing problems, and memory problems. Most people are aware of Alzheimer's disease being the most common cause of dementia. Well, stroke is number 2 on that list. Stroke, and in particular having had multiple strokes, is the 2nd most common cause of dementia. Despite all of our advances in medical treatment and technology, the mortality rate associated with stroke is still far too high. There's an overall fatality rate of 30%, and aspirin-like medications in and of themselves will reduce the risk of a stroke by anywhere from 20 to 37%. So one quick slide on this irregular heart rhythm I keep alluding to. So atrial fibrillation is an irregular heart rhythm, and it does increase the risk of stroke. And the incidence increases with age. 2 to 4% of patients in their 60s will have AFib, but that increases closer to 10% in patients 80 and above. And the annual risk of stroke, if untreated with atrial fibrillation, is 6%. And if people are on Coumadin and a blood thinning medication, we reduce that risk closer to 1%. So a significant improvement. Okay. Now there is a new medication called Pradaxa. Some people might have heard of, okay? And that's something that they can talk to their doctors about. There is an alternative to Coumadin. In my own experience, unfortunately, most insurances don't cover this medication. So although we have an alternative to Coumadin, patients are expected to pay $250 a month out of their pocket for this medication, and that's not realistic, okay? Now that should and will change with time, but as of right now, that's a significant limitation to this other Coumadin alternative being available. So at Cape Cod Hospital in Hyannis and at Falmouth Hospital, we are designated primary stroke centers by the Massachusetts Department of Public Health. At Cape Cod Hospital, we've had a stroke program by the wonderful Pauline Feely in the back since 1997. So we've been doing this for a very long time, but we had our official designation in 2005. And we have a stroke committee that meets regularly, composed of neurologists such as myself, ER doctors, nurses, rehabilitation specialists. And as of July and August of 2005, both Cape Cod Hospital and Falmouth Hospital are designated stroke centers. And fortunately, due to some what I feel is very good stroke care, we have won some nice accolades and won some awards recently, been recognized from the Massachusetts DPH. So hopefully people will take away that stroke is a medical emergency and time is brain. The sooner we evaluate people, the sooner we start the necessary treatments, the better the outcome. And do not ignore stroke symptoms because they went away, okay? If people are with someone who has transient weakness, transient numbness, transient incoordination on one side of the body, this is an emergency just as if symptoms were permanent. And this is a time we have to intervene. When people have a transient ischemic attack or TIA, this is a time where we can address all of their stroke risk factors and make a difference and prevent that stroke from happening. And again, act fast, that mnemonic, and T standing for time. So thank you very much for your attention. Hopefully everyone will take home one or two new pieces of information about stroke. And if anyone has any general stroke questions, I'd be happy to try to answer those at this time. Yes?
Somebody told me if you think you were having a stroke, take 2 aspirin, even though you say you're on aspirin already. To be safe.
Well, with the benefit of aspirin, turns out the benefit is if taken within 48 hours of a stroke. Okay, so whether you take it at home or we give it to you in the hospital a few hours later, the benefit is still there. A lot of patients with stroke will have difficulty swallowing. Okay, so you might take something, you can go down into the windpipe instead of the food pipe and cause a pneumonia and a whole nother source of problems. Okay, so what I would recommend is call 911, we will take care of the aspirin.
What about if you do have a lot of plaque in your arteries, is there anything you can take that and get rid of the cholesterol or the plaque that's already there?
Yeah.
Medications to slow it down or stop?
Yeah, that treating high cholesterol, blood pressure, and medications like aspirin can reduce that plaque. It can stabilize that plaque. Oftentimes the blockage will be ulcerated or very friable, and these medications can stabilize that so it will be smaller. Now, we always need to monitor if there is any degree of carotid artery blockage. We need to follow up with serial ultrasounds down the road. And the critical number that we use is 70%. And if a carotid artery is 70% blocked, the risk of stroke outweighs any risks of surgery to fix it. There are surgeries that can go in and remove that plaque. But we don't do that in everyone with plaques and blockages of the carotid artery because we know that your risk of stroke doesn't increase to a point where we would want to put you through the risk of surgery until it's closer to 70%. Yes, in the back.
Is Pradaxa more effective than Coumadin?
Pradaxa, there are no head-to-head trials. Pradaxa is equally effective as Coumadin. One thing I will say about Pradaxa, because you mentioned it as well, is that if people are on Coumadin and they have a complication, which is typically bleeding, we know what to do to stop it. Okay? We know that we can give vitamin K and other treatments to reverse the blood thinning effects of Coumadin. We do not have that ability to Pradaxa. There is no antidote to Pradaxa. So if someone comes in with bleeding complications related to Pradaxa, we don't know right now how to stop that. So newer may be better, but not always. Yes?
Coumadin, is there a limit to how long you can take it?
No, some people are on Coumadin their entire lives for a variety of reasons. Some people have heart valve abnormalities for which they need to be on Coumadin their entire life.
If it works well, why wouldn't somebody want to be on it? all the time?
Well, there's very specific indications for Coumadin. And Coumadin, like aspirin and other medications, do have risks. And the main risk of Coumadin is bleeding. So you always have to outweigh the benefit versus the long-term risks.
Okay, thank you.
A person over 80 arrives in the hospital in an ambulance with 2 or 3 of the symptoms of a stroke.
Yeah.
What do you do?
All the things that we talked about, evaluate them.
No TPA.
No. Oh, absolutely. We use TPA in people over 80. We absolutely do. Age is not an exclusion for giving TPA. So if you're 80 or you're 90, we will evaluate you for receiving TPA. But we always tell people, and I counsel people when I'm talking to them and talking to the family, is that we know that in the handful of studies, when they included people in their 80s and 90s, the risk of bleeding was higher than 6%, and the benefit didn't seem to be quite as high in younger patients.
Is that the first treatment that's given when they arrive in the emergency room?
TPA is the only available treatment for a blockage of a brain artery in ischemic stroke. Okay, and again, it's only given to 4% of all patients. Number one, the most limiting factor is that 3-hour time window. But there's over 20 other reasons why they can't receive it. Certain other medications that they're on, recent surgeries, other medical conditions. We have to go through a whole checklist of reasons why they may not be able to receive this medication. Yes?
If you wake up in the morning, you have a numbness in your face, and you
Yeah.
already have carotid blockage to some degree, is that pretty much leading in this direction of stroke?
Well, sure. If this numbness is new for you, then absolutely. And one thing that it's a good time to mention in terms of stroke symptoms. We all have random numbness and tingling here and there. We all have lightheadedness here and there. If people have numbness of just the face or just the arm or just the leg, it's not as concerning for stroke as it is just pinched nerves and other problems, okay? If you ever have any questions at all, just call 911, go to the hospital. Lacunar, yeah, so lacunar is an old term that refers to a small stroke, in particular less than a centimeter. The definition of a lacunar stroke is less than a centimeter and typically in a deep part of the brain. So looking at the CAT scan here, lacunar strokes are very common. 25% of people over 70 will have a lacunar stroke on CAT scan when we do a CAT scan for God knows what reason. Okay, so 25%, 1 in 4 of people will have had a small stroke in the past and not even know it. This is a silent and incidental finding.
And it's gone through the rehabilitation process. And they're sent home. When they get home, the memory lapses continue. Should they, what is the next step?
Well, stroke and in particular...
Is that going to continue, or is there a treatment for that?
Well, stroke can absolutely affect memory. And again, stroke is the #2 cause of memory problems, right behind Alzheimer's disease. The same medications we use to help memory with Alzheimer's disease are also used in stroke-associated memory problems. Aricept, Razidine, Exelon, Namenda, these are the medications that we use for Alzheimer's disease, but can be helpful with stroke-associated memory problems as well.
So that person should go back and see the doctor?
Should see their primary care doctor, absolutely, and or a neurologist, yes.
If you have a mild stroke, and then you have another stroke after that, will they be worse? Will there be more damage to your...
No, not necessarily, and that's one of the frustrating things about stroke is that it just affects on the part of the brain that's affected. Again, many people are walking around who have had small lacunar strokes and they don't even know it. It never caused weakness or numbness or clumsiness or memory problems or speech problems. It just happened. Knock on wood, okay? So it really depends on where the stroke is. Yes, on the side.
Doctor, could you comment? I have read in the past that there is a difference in effectiveness between regular aspirin and safety-coated aspirin. Could you comment on that?
In terms of stroke prevention, there is not. And again, the dose of aspirin, whether it's enteric-coated or not, whether the dose is 81 milligrams or 20 times that dose, it doesn't matter. The 81 milligrams of aspirin, be it enteric-coated or not, is equally effective as higher doses of aspirin in preventing stroke. Yes, sir.
Is there any risk changing from Pedaska to Coumadin?
Well,
And you want to go to Coumadin, is there any
It's very individual. They're both blood thinners, so the risk of bleeding is typically the case with both. But always, I'm hesitant to answer any more individual questions because there's always a lot of personal and factors that could come into play. So it's always an individual decision based on the patient and based on their other medical problems. One more question, yes?
Can you take aspirin if you have acid reflux, like the coated aspirin?
You can, but it can make that acid reflux worse. Okay, so that's where an enteric, a coated aspirin, would be tolerated better than a regular aspirin. Hopefully it would not upset the stomach as much. But sometimes people find that if they have any reflux and they take aspirin or Plavix or Agronox, symptoms get worse. Fortunately, oftentimes we can increase the doses of their reflux medication and then things quiet down. So one more question. I'm sorry.
This has to do with the aspirin getting.
Yep.
Do you have to take it every single day, or can you, because if I take it too often, I end up having problems with bleeding.
Mm-hmm. Yeah, and that's why, you know, I'm trying to make some comments which are relatively global, but in the case of any medication, it's very individual. So there are some people who cannot take aspirin safely on a daily basis. So in those cases, every other day is better than none at all. So thank you very much for the opportunity and for your time.